Thank you, Dr. Stevens, and thank you for a great overview of the challenges facing trauma care in low and middle income countries. We start out with a broad approach, and now we're going to become a little more specific. Daniel Wako is going to come and talk to us, who is the program director for risk communication and emergency response in Kenya, and also works for the Division of Global Health Prevention for the CDC. Daniel, thank you for coming. I know you have much more important things to do these days for the CDC, but thank you for taking the time to come and visit us and talk to us about a specific example from Kenya.
Thank you very much. So, thank you very much. As was said, my name is Daniel Wako, and okay. The title there was about, I think, trauma care. Okay, is it? Okay. But what I'm going to talk about is basically the development of EMS in Kenya and the stages that we've gone through and the development and things like that, and looking at it from a perspective of the challenges we've gone through, the opportunities we've had, and the different stakeholders that have come in. So basically, I'll begin with the problem. One is just a bit of background, looking at Kenya. Kenya is a small country in East Africa, basically a population of about 40 million people. It's a low-income country, as has been said. It's prone to a lot of emergencies and disasters, and then emergency response to mass casualty incidents and disasters remains weak. And there's also a lack of unified response, basically by fast responders. And this is mainly from the perspective of emergency response or response to disasters. And the reason that I've talked about here is mass casualty incidents is from a disaster perspective. As some of you may have known, Kenya did have an attack at a mall, Westgate Mall, in 2013. And the response to that was felt to be a bit weak, and a bit of coordination issues were noticed by a lot of people. And because of that, there was a feeling that there's a need for all the stakeholders to work together so that response can basically be done better. This is a bit of the context. Kenya has a large number of ambulance providers and ambulance vehicles. Many of them are private. Many of them are working in very different states. And you have the advanced level type of ambulances, and some are very low level. So you have a mix in terms of the types of ambulances, the number of ambulances, the distances ambulances have to go to, and then the connection between pre-hospital care and hospital care, where you have ambulances that are very advanced, but the hospital that they may be going to may not be as advanced as the ambulance is. The picture that you can see is a group of 70 ambulances. One of our counties, Machakos County, did purchase 70 ambulances. So EMS personnel, EMTs and paramedics are not a recognized profession like doctors and nurses in Kenya. This presents a challenge for many reasons. One is because they're not recognized, jobs may not be there for pre-hospital care workers. So as a profession, it's very difficult for it to grow. And then there is no official or standardized Kenyan curriculum for training of EMTs and paramedics. There are a lot of different groups. Kenya Red Cross, one of the big responders, which is mandated by the Kenyan Constitution to actually assist in emergency response, does have their own training. There is Kenya Council of Emergency Medical Technicians, which does a bit of training. So there are many organizations doing different trainings, which have different requirements. So the issue of standardization that was mentioned by Kent becomes something of a challenge in terms of if we're saying you're an EMT or you're a paramedic, it's difficult to say what exactly in terms of training and experience do you have, because there's no real certification or standardization as far as training is concerned. There is, again, no official licensing or certification authority in Kenya. So in terms of any one of you can right now pretty much go and be an EMT in Kenya, because there's no regulatory body or authorizing certifying body. And then access to EMS. We've talked about access because the issue is from the site of the incident, if you have an accident, if you have a disaster, or you're at the site of an incident and you get injured in that site, how fast will it take from the time someone knows that you're injured to the time the response comes, to the time it'll take to get to the site? So one of the challenges we do have in terms of access is there's no national short digit number for EMS, and each ambulance service has their own number. So we have so many ambulances, so you'd have to pretty much know the ambulance number that you can dial in terms of an emergency. We have had some breakthroughs in terms of that because the police number, 999, used to work, I think, about 20 years ago. Then when cell phone coverage came in, the interconnection between cell phone network and standard landline phones was not interconnected as it should have been. So the 999 number stopped working. But it was reinstated, but it works for police. So there's this connection again between when you dial 999, it goes to a police. And you know, security dealing with medical, again, that interface is not as good as it should be. So we've tried to engage police as much as possible because many people can dial that number, but the connection between police and medical needs to be made faster. Then there is no national ambulance system for the general public. And this again comes to the fact that there are some insurance schemes that are available for some Kenyans, and those insurance schemes have a component of pre-hospital care where there's an ambulance attached to the insurance policy. So those people who would have that policy would have access to ambulances, but people who are not on that policy may not have access. So it's not equal access to everyone. And then the third point is there is no legal ambulance standard as far as defining what an ambulance is. These are some of the newspaper articles that I was able to get over the years. Just a brief overview of some of the things that we face, from disaster of poisonous gas. The one down there is a pipeline. There was a pipeline fire. This was an oil pipeline, so 120 people actually got injured during that. Pipeline explosion in a very densely populated area. There was a flash flooding and pretty much fire. So many of the disasters we face are fire and explosions, building collapses and things like that, many man-made kind of incidents. This is what we see sometimes. When an ambulance is called a killer ambulance, it's almost like ambulances should be saving lives, but this is saying killer ambulances. So there's sometimes when ambulances do come, this is what we end up seeing because of no real standard as far as an ambulance is concerned. As I said, not all ambulances look like this, but right down there, that's actually the stretcher inside the ambulance. So many people would be very concerned to be being carried by that. But because we don't have real standards as such, it becomes very difficult to regulate and say that this is wrong because we don't have what's the standard. But the work that we've been doing so far has been to work with what we call our Kenya Bureau of Standards. And the Kenya Bureau of Standards has been very helpful in terms of developing a standard that an ambulance should have at a minimum a certain amount of equipment, a certain size, a certain ability to go certain speeds, certain lighting, markings, things like that, to recognize that this is an ambulance. So we've made progress on that. The challenge has been that despite having this, it is something that is not enforceable, and it comes to the issue of enforcement, because people can agree that this is a standard that is good and it meets certain requirements, but if people are not, and there's no enforcement as far as committing to those standards, it becomes difficult to really make them work. So this is a general timeline of some of the things that have basically happened from 1998. And 1998 for Kenya is a very critical time because that was when the embassy bombing happened on August the 7th of 1998. And that was when Kenya as a country realized that emergency medical services was not as strong as it should be because it was not able to meet the demands. Many of the victims from the embassy bomb blast were actually taken by Good Samaritans in different vehicles because we did not have that capacity at the time. It was from there in 1999 that the first group of what we are calling paramedics and emergency medical technicians were taken for training. I think it was a group of 50, and we're very privileged that one of the people in that class was actually Bethwell, who's my colleague from Kenya. So he's been one of the first group of people who are trained to be the EMTs, and he's still in it this 17 years later. And the good news is from 50, today they're almost 700, so the trainings have continued, they've grown on, and they're in different industries, and they've gone to work in different places, and many of them have started working even in Kenya Red Cross. Kenya Red Cross began in 2008, as you can see. What I tried to do is above in the blue lines was many of the major things that happened as far as EMS is concerned, which is a number of meetings were held from 1999 till about 2008. 2008, 2009, and those meetings were people feeling that the change needs to happen, EMS needs to be developed, but was not growing as an industry as such, as much as people are getting trained and things like that. Then when Kenya Red Cross came, Kenya Red Cross tried to strengthen it and develop standards, and we as CDC basically got in about 2010. And in 2010, what we did is called all the stakeholders together and began what we're calling EMS symposiums. And then from there, we got in touch with John Hopkins, and since then we've been having symposiums every year, and with the idea of bringing people together to one page and standardizing a lot of these issues that were being talked about. So as you can see at the bottom, we had the post-election violence. These are all incidents that needed a lot of response as far as emergency management and response is concerned. So this is the symposiums that I've talked about. Basically, we had them with John Hopkins in 2012 and 2013. And last week, we did have what we called the first national mass casualty exercise. And this is something that we had been trying for a very long time, because we discovered that as much as we were training different groups of people who were working in a response, when they came to a disaster, they were working together. But when they were training separately. So the interconnection between the ability to work together in a disaster, we felt it's an important thing to actually train together. So after I speak, I'll actually show you a bit of a video of the exercise that we carried out last week, which we felt was very successful and was able to actually bring a number of stakeholders. I think they were from almost 20 organizations, almost 270 people were brought together to carry out the exercise. These were the 4 key objectives of what we have been calling the EMS Symposium, and bringing these groups of people together annually. One was to create synergy between organizations working in EMS to enhance collaboration, because what we did discover is that different organizations had different strengths and weaknesses, and when they came together, they could actually learn from each other and find ways of collaborating. And then 2 was to develop minimum standards for ambulances and first responders. This is in the component of training, in the component of vehicle standards. And we've been able, as I said, to make some progress as far as developing standards. We have been working on a policy that also will streamline some of these things. Number 3 was to explore mechanisms and opportunities for resource mobilization. As all of you may know, emergency medical services is very expensive in terms of the equipment, the training, and all the needs that it has. So there are costs that are there. So engaging partners and finding ways that resources can be brought together to basically strengthen and empower people working in EMS. And then the 4th was basically to provide a forum for interaction and exchange of ideas and best practices. This is just a picture that we took during the symposium, and these are the logos of some of the people who are basically involved. We had St. John's, we had the Kenya government, CDC, John Hopkins. The corner there is Kenyatta National Hospital, which is our level 6 hospital. Basically, most trauma cases that are serious and most emergencies are actually referred to Kenyatta National Hospital. So those are need to engage them from the aspect of looking at, we are working with pre-hospital care, but the hospital needs to be engaged such that when the patient is received from the site, they're actually taken into the hospital and treated well. And then the Kenya police, and the Kenya police were here basically because every time we have an incident or accident, the police usually are the first people on the site. Police spread within the country is quite elaborate, and they're usually the first people to arrive on the scene. And if it's a criminal case or investigation, they can begin the investigation. So the use of police is one, because most people report it to the police if it's a fire or destruction or a terrorist event. And then police can basically engage the hospital, engage the first responders, and work like that. The process has basically been to unify all stakeholders in a shared forum where ideas and resources can be talked about. And then Over the years, we've come with what we call the big four and the one cross-cutting area. And these are the big four in terms of trauma care and emergency medical services in Kenya. We felt that if these four issues are basically addressed, you can actually have trauma care and EMS and pre-hospital care basically working in a system. And number one is communication. Because if an incident happens or accident, someone needs to communicate what has happened, where did it happen, what do you need at that site, letting these people know so that they can inform and dispatch the items that are needed for a response. The second item is data management. And I think from Ken's presentation, he talked about the use of data. Data is very limited in low-income countries because, again, not many people collect data, and then when data is collected, the integrity of that data many times can be compromised. Many times we're dealing with paper collection of data, so there's the translation and how that data is basically retrieved, stored, and used. And then there's the issue of transport. If you call an ambulance in the US, there's a minimum standard of what you're expecting to see. We felt that we need to create a minimum standard, which I've kind of talked about in terms of if you say an ambulance is coming, you should not be surprised by what you see. And then the fourth element is training. If you're going to say you're trained as an EMT, there needs to be a certain level of training that you reach as a minimum. Everyone can be trained above that, but not below that. So a minimum level of training. And then the fifth one that is cross-cutting is basically legislation and policy. For all these to work, and they're interrelated, there needs to be a policy and regulatory framework that makes all these things work. Because, and I'll begin by just talking about each of these four elements. One is communication. In communication, we're looking at basically how data is sent, received, shared, utilized, and stored. Those 5 components of communication need to be very clear, such that when messages are sent, they're received at the right places, communicate to the right people who can utilize that information and basically use it to make decisions that are made. We had 2 key challenges as far as communication was concerned, which was most emergency numbers were unknown by the general public. So we began by sharing the numbers to all the stakeholders that we had so that people knew what were the latest numbers people had. And then the second one was increase access to EMS services to all citizens. What we've been working towards is the establishment of a toll-free number for EMS. The 999 number, as I said, has been established. We're looking at how can that number be basically integrated for emergency medical services. 2, again, data, similar issues, the collection, sharing, storage, retrieving, and using of that data. As was said earlier, the information has been very little. I think some of the actions that have been going on is what Kent mentioned before me, is the collection of data at trauma, the formation of trauma registries, making sure that in those trauma registries, we actually have elements of pre-hospital care being collected there, which is a start in terms of collecting information, but it begins to inform the way things should be. Then the second one was no legal framework, so develop a national EMS database, which is a long-term item that we hope to carry out later on. And then 3 was there was little research on EMS. So now we're working with partners and looking at carrying out more research using available data and developing and strengthening the amount of data that's available. This is the kind of form that's being used. Some of you may have seen it. And this is what we call the patient care report form, the PCR. And we basically collect 5 key broad areas of data. 1 is demographics, 2 is medical history, 3 is the physical assessment of the patient when they're picked up, and then number 4, we're looking at the cause of the injury. So we'll be looking at what caused the injury, and then the response time. Response time, the bottom one, is critical for EMS and trauma care, because how long it takes for a patient to get to the site of treatment and what kind of treatment is being given to them on the way to treatment is critical in terms of survival rates. Limited data has meant many things. These are just some of the four. One, it's difficult to measure success or progress. You can't know if you're doing well or badly if you don't have the data to support it. Two, it's been difficult to determine and prioritize needs of the community because, again, we would use the data to inform the training. If we say most people are getting head injuries, then we'd need to inform our training and make sure that head injuries are actually put into the curriculum. If we say most injuries are happening at night or Friday nights or on this road, then we can basically make sure that the ambulances, the training is informed in such a way that responses are better because of the data that we do have. And then it's difficult to obtain the denominator, the baseline. Where are we starting from? Are we improving? Are we getting better? Are we moving in the right direction? Are we going where we need to be going? And then the fourth element is there are challenges with verifying data. Again, when you have private sector responding in terms of looking at ambulances, they may inflate numbers to say they're doing more work. When you have government involved, they may reduce the numbers, trying to say that there are less people getting injured. So again, how do you triangulate that data and make sure that that data is actually accurate? The third one is transport. Here we're looking at four key things: what it should look like, what it should contain, what it should be able to do, and what it should be used for. If an ambulance comes, is it for transfer? Is it for transport? What is the ambulance supposed to do? And I said the challenge was there was no standard, and we've worked with Kenya Bureau of Standards. We've released the new standards that are by Kenya Bureau of Standards. The challenges there are two. One is you have to pay for it to receive the document, and then two is no one regulates that as far as conformance to the standard. Then the second point was there was no standard for training of ambulance operators, and then ambulance driver skill training was a proposed action, and then currently ambulance operator trainings are now available to train ambulance drivers to do what they need to do. Then the training, again, there were four key issues we're looking at. So it's the curriculum, it's the duration, how long should the trainings be, what are the prerequisites, and then who does the certification and recertification of trained personnel. So the issues were there's no standardization. So actions we've taken is standardizing trainings and trying to come up with a curriculum. We're working with what we call the Kenya Institute of Education, developing a curriculum that hopefully will be implemented nationally and people would have to comply with that. And then the second point we're doing is EMS of different qualifications employed. So it compromised quality of care. So development of minimum standards for recruitment. If we're saying you have to get a certain grade or be of a certain education level to become an EMT, then that's what we're saying is a prerequisite for students to become EMTs and paramedics. And then, yeah, the third challenge was no official curriculum. This is the progress we've done so far. This is 2010 to 2014. Is training. Curriculum is being worked on, as I mentioned, through what we call the Kenya Institute of Education and stakeholders. So they're in the developmental stages of developing a national curriculum. And then there have been new partnerships like Johns Hopkins, the Kenya Bureau of Standards, the AMREF, Flying Doctors, National Disaster Operations Center. We've also partnered with some lawyers, international legal affairs. And then we've increased number of ambulances. I think in total now there are over 100 ambulances. There are, as I said, easily the EMTs numbers are almost 700. And then road infrastructure. For those of you who have been to Kenya, we do have a lot of traffic challenges, but the road infrastructure has also improved. We've got also a lot of roads, which is making response time a bit faster. And then we also have the annual EMTs Festival, which is being organized as a way that different organizations can come together and basically test what they're doing. And then the issue of 999 number that I've talked about. These are the challenges. Of course, without anything that has positive things has to have some challenges. Some of the challenges is to keep the group energized. As I said, I've started in 1998. I think the first ambulance came to Kenya, and Bethel can correct me if I'm wrong, in 1901. Bethel, was that the case? 1901. So I think we've had an ambulance for easily over 100 years. But in terms of response and being fast enough, it's really since 1998 that things began to change. In South Africa, there is one Western Cape, one province that really has a very advanced system. It took them 40 years to develop it. So when you look at the amount of time it takes to develop an EMS system with the challenges of limited resources, 40 years could be a short time. So we've been doing it almost 17 years, and that is almost like halfway. So we have a long way to go, I think. But it's encouraging to see the amount of progress that has happened, because if you look at cell phone penetration, in Kenya it's almost, I think, 80%. So communication has improved very drastically compared to what was happening in South Africa. Then again, there's limited funding for preparedness. Donors prefer response. Response is easy to justify, it's easy to show, it's quick. But preparedness takes long, it's difficult to show the results as easily as response is. And then tasks are interrelated and interdependent, and there's a lot of dependence on the government and what's going on. And then data sharing among organizations remains a challenge because of competition. We have really tried to make people understand that they can complement instead of compete, because there is enough response for everyone to actually work in the environment. These are the opportunities we've seen. One is the new constitution. In my timeline, I didn't talk about it, but in 2010, Kenya did get a new constitution, and that new constitution for us opened doors because it actually provides for emergency care as a right for every Kenyan. So we're trying to use that constitution as an avenue for that to improve. And then I've talked about cell phone penetration, the legal policy frameworks. The gaps present an opportunity. And then this is the way forward, basically working with partners in policy and legislative changes that will highlight EMS, strengthen data collection through increased documentation and challenges of opportunities. And then looking for evidence-based solutions, and then enforcement of Kenya Bureau of Standards. And then these are the acknowledgements I have, basically John Hopkins. Okay, yes, so that's, I don't know if I can show, can I show that a bit, or the time?
Sure. I think you can hold
Yeah.
We are here at Amani Village and we want to understand
So no one was injured during this, just for... So just to give a background on this, we were following It was 80 minutes. So, I need to reduce. So basically, the background of this was following Westgate, and this was the first time that we brought different stakeholders together, because we discovered that as much as everyone trained on their own, when we respond to disasters and emergencies, we respond together, and we could not coordinate working together. So the incident was basically an explosion. We had 30 casualties, 2 very critical, who are categorized as red. We had a police helicopter that came, flew out 2 people. We had search and rescue teams. We had hazmat teams. We had bomb squad teams. We had what they call the wrecker squad. We had a total of 270 people in this. So the coordination of this took almost 9 months of planning, but the upside of this was people got to understand that there are different roles during an emergency, and everyone needs to do their part. What we did have, if some of you did watch the videos of Westgate, is we did have fast responders like ambulance and medical personnel going into the building. What we did here is we had hazmat teams, which you can see going into the building first to check the building for safety. And then from there, we did have security teams, bomb squads. And then when they ensured that the building was safe, the bodies were basically being removed to the door, where now medical personnel would take over, so that there is that difference between hot zones and safe zones. I mean, the whole hot zones and cold zones, the danger zones and safe zones. Because that was one of the weaknesses we did find during Westgate. So the video is long. We won't be able to show it, unfortunately. It'll be, I think, available later on somehow. But it's something that has never been done before, where we actually integrated police, military, civilian, government, private sector, and I told you that the whole thing took 270 people. So just the coordination of this was difficult, but very successful, and we're hoping that we can do this annually. Thank you.